Well, certainly some of the most exciting news at this year's scientific sessions of the American Heart Association were the results of the ATLAS ACS 2 TIMI 51 study. And I wondered if you could explain for our audience a little bit about that trial design and the patient population involved before we get into more details of the results and so forth.
So this trial was a study of low-dose oral anticoagulant with a novel 10A inhibitor and very low-dose anticoagulant with the same novel 10A inhibitor against placebo on top of dual antiplatelet therapy shortly after an ACS or heart attack. It was an interesting hypothesis that it's been shown previously in warfarin meta-analyses and studies that low-dose anticoagulation may potentially have increased benefit for patients with recurrent cardiovascular events. Testing these novel anti-10A therapies may have even improved benefit given they may have a lower risk of bleeding. And so this study was a randomized controlled trial, several thousand patients all over the world, comparing these drugs for outcomes, and they were followed for several years thereafter. And what was very interesting was the reverse dose response in the rivaroxaban arm patients compared to the placebo. So those patients who had low dose had improved cardiovascular benefit with regards to the triple endpoint of cardiovascular death, MI, and stroke, as well as cardiovascular death and all-cause mortality compared to placebo. But the very low dose had even better outcomes, with even lower rates of cardiovascular death and all-cause death. Very interesting to see that a lower dose of oral anticoagulation, a very low dose, has actually improved benefit. Of course, with less bleeding, and that may be one of the drivers to the improved benefit.
Well, it was certainly very interesting to see these results with the very low dose, the 2.5 milligrams twice a day of rivaroxaban, looking to be the better of the options in the two doses studied here. Can you tell us a little bit more about the safety? Because obviously clinicians may be concerned about adding any dose of anticoagulant to a potent antiplatelet therapy after acute coronary syndrome.
Of course, and we've seen that in other more potent antiplatelet studies. And so the rates of major bleeding were increased as expected with either the very low dose or low dose oral anticoagulant on top of placebo, on top of dual antiplatelet against placebo. However, the rates of fatal bleeding were less than in the very low dose compared to the low dose, and was statistically not different than the placebo group for the very low dose of the rivaroxaban arm. As well, in terms of intracranial hemorrhage, there was no statistically significant difference with regards to fatal intracranial hemorrhage, although the rates were increased for intracranial hemorrhage with either the very low dose or low dose.
So what do you think this means for clinicians going forward? This very low dose of rivaroxaban, 2.5 milligrams twice a day, looks like a promising addition to existing dual antiplatelet therapy post-ACS. But we have several antiplatelet drugs to choose from now, and what do you see going forward, or whether other studies need to be done here?
Well, I'm almost ready to compare this to the Muhammad Ali against Joe Frazier. We've got two heavyweights now in terms of real impact in clinical practice potentially. We have the ticagrelor results from Plato, which was more potent dual antiplatelet therapy. We also have the results from prasugrel, which was more potent dual antiplatelet therapy against, again, clopidogrel showing increased benefits, of course with a trade-off of increased bleeding. And now we have the results of the ATLAS 2 ACS TIMI 51, very low dose rivaroxaban on top of dual antiplatelet therapy having improved benefit. So the question really is, what happens if you compare these agents against each other? Whether that trial is going to be conducted remains to be seen, but I think that will be the elephant in the room, that most people want to see these two agents up head to head.